On the policy side of things, or the political side of things, there's not a lot of consensus about the scope for defensive medicine. So on the policy/political side, on the high end, the highest estimate I could find is from Tom Price, former Secretary of HHS, who estimated that 26% of all healthcare spending can be attributable to defensive medicine. This is clearly quite high and stands in pretty stark contrast to work from CBO, which has estimated that even with dramatic liability reform, we could only decrease healthcare spending by about 0.3%. On the academic side of things, this question of defensive medicine has motivated a pretty extensive literature. Generally, what this work has done is to study the impact of malpractice pressure by looking at the effect of state-level tort reforms. Most commonly, this work looks at reforms that impose caps on the monetary damages that claimants can receive in the event that they win a malpractice suit. By and large, what this literature has found is that these state-level tort reforms don't have a large effect on physician behavior. So if you look at these states with and without tort reforms over time, we can see that they have similar spending patterns. They also look similar in terms of the supply of physicians in the area. Based on these findings, there's a loose academic consensus that the scope for defensive medicine is relatively small. However, if you look outside of these tort reforms, there's very little evidence on how physicians are responding to other dimensions of malpractice liability. So in this paper, we take a different approach to studying malpractice, and we ask, how do physicians respond to specific malpractice allegations that are made against them? And the intuition here is that a malpractice allegation is more likely to have a direct effect on physician behavior relative to these damage cap reforms. So that's for a couple reasons. First is that empirical evidence has shown that physicians are not well informed about their state's tort environment, suggesting that the salience of these tort reforms is relatively limited. Second, physicians tend to have generous community-rated malpractice insurance that covers claimant damages in the event of a suit. So these damage cap reforms aren't actually having a direct financial impact on physicians. Malpractice allegations, on the other hand, are common and highly salient to physicians. About 75% of physicians will face a malpractice claim during their career, and these allegations carry uninsured risks or uninsured costs like reputation damage, as well as any psychic or time costs associated with the suit. So we're going to study the impact of malpractice allegations against emergency department physicians in Florida, where we can link the universe of ED discharges with a database of closed malpractice claims in the state. We're going to study the impact of allegations using an event study difference in differences approach, where we look at reported physicians before and after their malpractice report, and we compare them over time to their unreported peers. In terms of results, we're going to be interested in two types of effects. First, we're going to see if malpractice allegations influence physician labor supply to see if physicians work less or stint on care after a report. This type of response is typically referred to as negative defensive medicine. And second, we're going to ask whether allegations influence physicians' treatment intensities, whether they spend more per patient or order more tests. This is typically referred to as positive defensive medicine. All right, so a quick preview of the results per Tal's comment in case my computer just crashes at any moment. So we're going to find that malpractice allegations have two offsetting effects. The first thing that happens when physicians are accused of malpractice is that they work less. And we're going to estimate that physicians reduce their discharge volume by about 6.5% after these reports. But then we're also going to find that among these remaining discharges, physicians increase their treatment intensity. We're going to find that they increase costs per discharge by 6.3%. I'm going to hold most of the discussion till the end of the presentation, but I want to take one moment here at the beginning to highlight these first 2 points in the context of the existing literature, which has typically looked at changes in aggregate state-level spending, which is going to be the combination of these two offsetting effects that we're finding in this paper. Then in the final part of the talk, I'll show you some evidence that physicians respond to all sorts of types of malpractice allegations, and these responses don't seem to depend on the legitimacy or the content of the claim. Okay, so jumping in, we're gonna study the impact of malpractice allegations using 3 main data sets. Our first data set is emergency department discharge from Florida. This data is nice for us because each discharge record identifies both the attending physician and the discharging facility. It also has sort of standard discharge data variables like year, quarter timestamps, patient characteristics, diagnoses, and any procedures the patient might have got during their visit. Importantly, this is discharge data. So we see patients who were discharged from the ED, but we don't see patients if they came to the ED and then were admitted to the hospital. Our second data set here is the Florida Closed Claims Database. This covers malpractice claims that were closed in the state between 1994 and 2016. This is public data, by the way, for people who are interested, and it is really detailed information about each malpractice claim. So it has information about the physician who was reported for malpractice. It has their license number and tells you when they were reported. It has information about the patient injury, like when the patient was injured, where they were injured, and a clinical description of sort of what went wrong. And then it also has information about how the claim developed over time. So for example, if there was a suit filed, how long it took the claim to reach the final disposition, and whether there was a monetary award. Our final data set is the Florida Practitioner Database, which gives us more information about physician characteristics like tenure and specialty. We primarily use this data set to restrict our focus to emergency medicine specialists who tend to work full-time in the ED and provide the majority of care in that setting. Okay, so our empirical strategy is going to leverage variation in the timing of malpractice reports. And so I want to give you some information about how these reports happen. The first thing that happens in any malpractice claim is that a patient gets injured. In the context of the emergency department, the physician may or may not be aware of the patient injury, which can manifest after the patient is discharged from the hospital. So you can think about a patient that a physician may have discharged with abdominal pain who shows up later with appendicitis. Even if the physician is aware of the injury, they're unlikely to be immediately concerned about malpractice. That's for a couple reasons. The first is that patient injuries do not necessarily imply physician negligence. And second, even in cases of negligence, the probability of a malpractice claim is very low. When a patient does choose to report their injury as malpractice, there's a lag between the patient injury and the malpractice report. In our sample, that lag is about 5 quarters on average. So what's happening during this time? Mainly, the patient is consulting with a personal injury lawyer and a medical expert who will work together to try to build a case against the physician. If at the end of this process, the attorney believes they have a winning case, then they will report the physician for malpractice. And this is the first time a physician knows with certainty that they're going to be facing a malpractice allegation. Once the malpractice report is filed, they tend to be slow to resolve. So in our sample, it takes about 9 quarters on average for malpractice reports to reach their final disposition. This time is mostly taken up with settlement negotiations. If the settlement talks break down, there might be a suit filing. Even then, settlement talks continue. And if they continue to be unsuccessful, the suit might eventually make it to court. You can see that happens only in a minority of the sample here. Okay, so as I said, our empirical strategy is going to leverage the quasi-random timing of these malpractice reports in an event study difference in differences approach. Our treatment group here is going to have about 300 reported physicians that we can follow for 2 years before and after the report. One important note here is that this restriction does not mean that physicians have to practice continuously for 4 years. It just means that if they were practicing, we could see them. So for example, we would not include a physician that was reported at the beginning of 2013 because our data is going to run out before we can follow them for 2 years. we pick control physicians using a 2-to-1 propensity score match, where we're matching the treated physicians to control physicians based on their characteristics in the quarter before their report. So we're trying to find controls who look similar to the reported physician right before they experience this shock of the malpractice allegation. I'm going to match on a variety of physician characteristics here, whether they're an MD or a DO, physician tenure, the region they're practicing in. We're also going to match on baseline discharge volume trends. We do this because it turns out there's lots of different types of ED physicians, even within these EM specialists. There's some full-time workers, there's some moonlighters. We want to make sure we're matching like with like here. I'm going to say briefly in the interest of time that our propensity score match is successful. We find matches for all but 2 of the reported physicians. And when we look across these treatment and control groups, it looks like the covariates are balanced after the match. Okay, so here I'm showing our estimating equation for the event study difference in difference. The beta Ks are the parameters of interest. They're measuring the impact of the malpractice report in the 8 quarters before and after the report is filed. The alpha Ks here measure changes among all physicians, not just the treated physicians, which gives the beta Ks a traditional difference in difference interpretation. Then we're also going to include a variety of sort of standard fixed effects here. We have physician fixed effects. We have controls for physician tenure, which changes over time by definition. We also control for calendar time fixed effects. We cluster our standard errors at the physician level. Okay, so here I'm showing you our first event study results, looking at physician labor supply. So what I've done here is plot an unadjusted event study of physician discharge volumes over time, separately for the reported physicians and the matched controls. You can see if you look in the pre-report period here, reported physicians tend to be high volume relative to these matched controls. But if you look at the trends are similar across our treatment and control group, and they're relatively stable over time in the pre-report period. Then once the reports are filed, these labor supply patterns diverge as discharge volumes drop among the reported physicians and remain relatively stable among these matched controls. All right, so here I'm showing you the analogous results, the analogous regression adjusted results from our estimating equation. So I'm plotting out the beta Ks here, looking at the effective malpractice reports over time. Hopefully this plot doesn't have any surprises based on the plot I showed you in the previous slide. But basically what we're seeing is that in the pre-report period, we don't find any meaningful differences in labor supply patterns across the treatment and control group. Then once the reports are filed, discharge volumes decrease among the reported physicians relative to the matched controls. And overall, we're seeing a decrease in discharge volume of about 50 discharges per quarter. Okay, so in the interest of summarizing and of scaling, I'm going to show you here the overall pre-post effect of malpractice reports as opposed to plotting out these separate estimates by event time. So the first column here is our main specification. It's basically a summary of what I've shown you in the previous 2 slides. We find that physicians decrease their discharge volumes after malpractice reports by about 55 discharges per quarter. This is about 6.5% as a decrease. To scale this a bit, ED shifts have about 15 patients on average. So a decrease in discharge volume of 55 patients equates to about 4 fewer shifts or 1 fewer patient per shift. In columns 2 and 3, I'm going to show you just a couple of robustness checks here, although we have many more in the paper. So in column 2, we rerun our analysis and we include in controls for other important events in the claim development. So in particular, the timing of the patient injury, the suit filing if it's relevant, and the final disposition of the case. So if you look at these coefficients, you can see, one, that none of the coefficients on these other sort of important events is statistically significant, and our estimated effect of the report is essentially unchanged. Another thing you might notice if you are sort of looking closely at the second column here is that we're estimating a relatively large and positive effect of the final disposition of the case. Clearly, you can see here that this result is imprecise, so I don't want to hit it too hard, But I can tell you that in complementary work where, for example, we plot out the effect of the report non-parametrically around the final disposition, we can see that there's a bit of volume recovery after the claim finally ends. Then in the third column, where we take away the timing controls, but we add in physician year time trends, the basic idea here is that, as in any event study, our coefficient of interest is identified off of variation in the treatment over time. In our context, that means physicians who have earlier malpractice reports as opposed to later malpractice reports in our sample. And of course, this is conditional on our physician fixed effects and tenure fixed effects, but nevertheless, it raises the concern that physicians who have these earlier reports might be different in some way to physicians that have the later ones. So we allow for this possibility in the third column with our physician year time trends. You can see when we run this specification, our conclusions are essentially unchanged. All right, so we find this pretty robust decrease in discharge volumes, and we'd like to know what's happening here. And so we start by testing a mechanism that's been proposed in the previous literature, which is that physicians respond to malpractice pressure by avoiding patients who are risky to treat. In the context of the ED, there's a couple ways this could happen. If physicians are in an ED where they have scope to choose their patients, then they can avoid risky ones simply by refusing to take responsibility for those patients when they show up to the ED. This would effectively leave them in the queue for their peers. If a physician is in an ED where they receive patient assignments in rotation, one way that they could avoid risky patients is by admitting those patients to the hospital. So an increase in admission rates here will shift the risk of treatment to the inpatient physician and will also look like a decrease in labor supply in our sample because, again, we only see the ED discharges. So unfortunately, in our data, we cannot track patients across hospital settings, and it is not possible to look at the change in admission rates directly, but we provide some sort of related evidence. And in particular, what we do is we sort of think about clinical severity by estimating decreases in discharge volume separately for patients who present with a high-risk condition like chest pain versus a low-risk condition like an ankle sprain that would be really inappropriate for inpatient care. So if you sort of do an eyeball test comparing across these graphs, which we've done in a more robust way in our paper, like you can see that we are estimating very similar decreases in discharge volume across these two risk types. And so overall, we're finding very little evidence of patient risk avoidance. Okay, so the next thing we do is we decompose the decrease in labor supply into extensive margin and intensive margin responses. So on the extensive margin, we're looking at the probability that physicians oversee any ED discharges to see whether they retire from practice in the state. On the intensive margin, we're looking at discharge volumes conditional on maintaining some practice. What we find when we do this decomposition is that our results are entirely driven by changes on the intensive margin. So if I can draw your attention for a moment to the left panel, you can see we're estimating a small and statistically insignificant change in the probability of maintaining practice in the state. But on the right-hand side, we're finding a large 7% decrease in discharge volume conditional on maintaining some practice. So I want to take one moment to sort of highlight these results again in the context of the existing literature, which has typically looked at the impact of state tort reforms on the supply of physicians in an area, and has generally found that malpractice pressure is not having a large effect on the supply of physicians. What our results suggest is that there can be a meaningful scope for these negative responses to malpractice pressure, even as the supply of physicians in an area remains stable. All right, so we see that physicians are not leaving the state, but nevertheless, there's this large decrease in discharge volume. And so we'd like to ask, are physicians shifting their practice around within the state? And in particular, we're going to ask, do physicians move away from the hospital where the patient injury occurred and shift their practice to a less demanding environment where maybe the patient volumes are lower, for example, at the hospital? We're going to take this in two steps. First, we ask, do physicians move away from the injury hospital, for lack of a better term, which is the hospital where the patient injury occurred? And here we find that the answer is yes. So in the sort of bottom half of this slide, I'm plotting out an event study where the dependent variable is the probability that physicians are maintaining any practice at the injury hospital. You can see from the graph that physicians do tend to leave the injury hospital after malpractice reports. There's a bit of a lag, but by the end of the period, we find that the probability of maintaining practice at the hospital where the patient injury occurred is about 5% less. So they're leaving this hospital, and we would like to know where they're going. We know they're not retiring entirely. So we're going to ask, when they leave, do they go to a less demanding practice environment? And here we find that the answer is no. So let me walk you through what we've done here. Our dependent variables are based on hospital characteristics. So we're looking at the share of physicians' practice that's at a teaching hospital, a safety net hospital, or a high volume hospital, where high volume is in the top quartile. The motivation for looking at teaching hospitals is that they tend to provide care to patients with complex or potentially risky conditions. The motivation for looking at safety net hospitals is that physicians have a well-documented perception that low-income patients are more likely to sue for malpractice. This actually turns out not to be true. Low-income patients are much less likely to sue for malpractice than higher-income patients, but nevertheless, physician perceptions are unmoved on this topic. Regardless, you can see when we look across these three rows, which are from three separate regressions, we're not finding any evidence that physicians are moving to different types of hospitals after the malpractice allegation. So overall, what we're finding here is that physicians move away from the injury hospital, but they move their practice to an observably similar facility. Okay, so what I've shown you so far is that malpractice allegations have a meaningful effect on physician labor supply. In particular, we're finding a decrease in discharge volume on the intensive margin. We're finding this decrease across all different types of patients, so it doesn't look like it's just for the risky patients. And we're finding that physicians do shift around hospitals a bit, but they're shifting to hospitals that sort of looked like the ones they were practicing at prior to the report. So we're not finding that this is driven from physicians going to a smaller, lower volume community hospital, for example. So overall, what we're finding in this first part of the talk is that physicians work less after malpractice reports, either taking on fewer shifts or working more slowly within a given shift. Now we want to shift our focus from these negative responses to malpractice allegations to positive responses and ask, do physicians increase their treatment intensity among these remaining discharges? We're going to measure treatment intensity here as the log of total costs per discharge. So we're moving to a discharge level analysis here, as opposed to the physician quarter level analysis we had for the labor supply results. The basic benefit of this is that with the discharge level analysis, we can add in controls for patient characteristics like age and presenting condition. Okay, so when we run these results, when we run our event study analysis, we do find that physicians are increasing their treatment intensity. So again, in the pre-report period, we're not finding any evidence that reported physicians have different spending patterns relative to their unreported peers. Then once the malpractice reports are filed, reported physicians begin increasing their spending more quickly relative to their unreported peers. Overall, we're estimating an increase in costs per discharge of 6.3%. If you look at this graph, you can see it looks like the treatment effects sort of maybe growing stronger over time. Okay, so a natural question about these treatment intensity results is whether they're driven by certain types of care or certain types of patients. So let me tell you, one way we think about this is to ask, is this spending increase related to the clinical risk of the patient? And we look at this in a number of ways, and when we answer the question, the answer is basically no. So again, let me walk you through how we've thought about this. We're going to think about clinical risk sort of by looking at discharges according to sort of the characteristics of their presenting condition. So in this top panel, we're going to separate discharges by their sort of ex ante complexity of their presenting condition. These are the categories that we saw before, where a low complexity condition might be an ankle sprain, a high complexity condition might be chest pain. The uncertain risk or uncertain complexity conditions, these correspond to the ill-defined conditions as defined by ARC, so not defined by us, but this includes conditions like a headache or abdominal pain, where the patient may have a very minor condition or they may have a more serious ailment, but it's not immediately apparent based on their initial symptoms. In any case, if you keep your attention on this top panel here, you look across the rows, which again are from 3 separate regressions, you can see we're not finding any evidence here that physicians are increasing their treatment intensity in proportion to clinical complexity here. And in particular, we're finding this large increase in costs even among these low-risk patients. So in the second panel, we're going to do a similar conceptual exercise, but we're going to think about uncertainty in a different way. We're going to group discharges into groups according to what we're thinking of as a protocol uncertainty. So what we're doing is looking at the coefficient of variation in costs within each discharge's presenting condition. So the idea here is that the coefficient of variation is a proxy for which the presenting condition is subject to uncertain spending or an uncertain treatment protocol. So we look at this in quartiles, but we could do it in a variety of ways. It doesn't turn out to matter. You can see if you look across these rows, again, we're not finding any evidence that physicians are limiting their increases in treatment intensity for these high-risk patients. All right, so to summarize what I've shown you so far, we basically find that malpractice allegations have these 2 offsetting effects. We have this positive response where physicians are increasing their treatment intensity per discharge, and this negative response where they're overseeing fewer discharges. And now what we like to ask is this actually evidence of defensive medicine? Typically, defensive medicine is defined as when physicians provide additional care in response to their malpractice concerns, where the value of that care is less than the cost. In our setting, we don't have a great way of valuing all of the additional care in aggregate to get at this directly, but I'm going to show you a few pieces of evidence that suggest these changes in care patterns don't look like they are beneficial to patients. So first, I'm going to show you that the increase in treatment intensity doesn't look like it's confined to high-value care. So what we're looking at here is the rates of specific imaging tests that have been shown to be either high value or low value in the context of the ED. So for high value care, we're looking at chest imaging, specifically chest CTs and x-rays, among patients who present with shortness of breath and also have some comorbidity that would warrant this test. So for example, a history of cancer. We're going to structure the low value tests in basically the opposite way. So we look at lumbar imaging among patients with uncomplicated back pain, look at head imaging among patients with uncomplicated headache. So basically focusing in on patients who don't have a condition that would warrant these tests. So when we look at these 3 results, you can see we're not finding any evidence that the increase in treatment intensity is limited to these high-value tests. In general, our estimates here are less precise than on the other parts of our analysis, in the labor supply analysis and the overall treatment intensity analysis. So they should be interpreted with that in mind. But to the extent we are finding changes in imaging tests here, we're finding them among low-value services. Okay, so the second thing we'll do to sort of get traction on this defensive medicine question is ask, does it look like physicians are changing their behavior because they're learning from their malpractice reports? So we're going to think about this in 2 ways. First, we're going to ask, are physician responses to malpractice concentrated among patients that resemble the claimant in their case? So for example, if a physician was reported for their treatment of a pregnant woman, we look to see, well, how do they change their practice patterns for future pregnant patients versus other types of patients? So in here, I'm plotting again, the overall pre-post effect. of malpractice reports, both for the labor supply analysis and the treatment intensity analysis. In panel A, we have our claimant similarity results. And you can see here, we're not finding any evidence of differential responses across these two patient types. And in particular, we're finding large responses to malpractice allegations, even among these claimant dissimilar patients. In the second panel here, we think about learning in a slightly different way. And we ask whether physicians respond more strongly to malpractice allegations if there appears to be some merit to the claim, like if it looks like they actually did something wrong. So here we're going to say a claim has some merit if it resulted in a payment to the patient, which is an imperfect proxy. But regardless, when you look across these 3 rows here, again from 3 separate regressions, you can see we're not finding any evidence that physicians have stronger responses when there's sort of larger and larger payouts. And again, in particular, physicians are having large responses to malpractice reports, even when those reports ultimately resolve in their favor with the $0 payouts. Okay, so I'm going to conclude by talking about the implications of our results for system-level spending. So we find our 2 main results are we find these offsetting effects of malpractice. We find a decrease in labor supply, but an increase in treatment intensity, sort of bullets 1 and 2 here. For the individual reported physician, these results are roughly offsetting. So it turns out that malpractice allegations don't have a large effect on the aggregate spending of the reported physicians. From a systems perspective, the decrease in labor supply doesn't represent a true decrease in resource use under the assumption that patients are still going to come to the ED and they're just going to be treated by a different physician. So for these patients, the true change or the social change in resource use is going to depend on the differential spending patterns of the reported physicians and their unreported peers who are sort of taking on more patients when their peer reduces their labor supply. It turns out that reported physicians do tend to be high spenders, even prior to the report. So reallocating patients away from them does save some money, but not a huge amount. So we're finding that unreported physicians have lower spending by about 1% on average. This is going to offset the increase in treatment intensity among the reported physicians for a net change in spending of 5.8% among these affected patients, where the affected patients are either treated by the reported physician or they're reallocated to a peer. If we want to think about the change in spending overall relative to all ED spending on all patients, then we find that malpractice allegations are leading to a 1.8% change, 1.8% increase, I should say, in spending overall. So I'll just conclude by saying, with the caveat that, of course, we've baked in a number of assumptions here. One is no spillovers onto unreported physicians. What our results are implying is that malpractice allegations can have a meaningful impact on physician practice patterns, even if aggregate changes in spending are relatively small. Okay, so with that, I'll turn it over and look forward to the discussion.
Okay. So first, thanks so much for the opportunity to discuss this work. It's really, really interesting. I know everybody always says that when they're discussing, but truly it was. You could go to the next slide, please, Jason. Thanks. So what the authors look at here is broadly in the context of what the effects are of malpractice liability in terms of whether it increases defensive medicine. And they're pretty unique here in focusing on the effects at the margin of the report timing. Okay, so quite unique in that sense. And they say that while physicians aren't directly financially liable for a report, there is some degree of a cost that's uninsured in terms of the physician's time and perhaps some emotional energy, I'd imagine, as well. And that this could lead to some defensive medicine also to prevent some future reports as well. Let's get to the next slide. Thanks. So instead of the more common method of identifying these effects through variations in tort law across state or changes in tort law within a state across time, they construct a difference in differences approach through an event study with matching on observables with having read through it with extensive care in this matching element as well. And they focus on emergency specialists in emergency departments. And they're really relying on the idea that the malpractice allegation itself, as well as the timing of it, is for the most part random and a function of how many patients the specialist is seeing, which is something that might be surprising to those, or at least to me, who are unfamiliar with this world as well. So can you go to the next slide? Okay, so the outcomes that they're going to look at broadly are, first of all, labor supply, and they're going to measure this as changes by discharge numbers after they've received a malpractice report. Again, not at the time of the injury, but just by the time that they're informed of the report, which is just going to capture the effects on their physician's time, as well as a defensive component. And then they also look at treatment intensity through log changes in costs per discharge, and looking at different types of discharge or discharges on different patients, which is going to capture primarily just the defensive response. And it seems like emergency departments are quite a nice place to study this, since the productivity element is quite important. There's a lot of uncertainty. You're seeing patients with very little information, with potentially very acute issues. And also importantly, ED physicians are not selected by the patients or the patients then. Next slide, please. Okay. So they find some really notable effects on both outcomes following a report. And I would say that these are quite large, considering they're within the context of already existing tort laws and insurance. So they're already in this world, and then on top of this, there's I would say a really large response of a decrease in about 6.5% per quarter in the number of patients that or discharges that these physicians are having, though that increases to about normal after resolution of the report. And then also in treatment propensity or cost per discharge, as Caitlin said, there's in a sense an offsetting effect in the total of amounts that they're charging. There's this decrease in discharges, but a very similar in magnitude increase in the charge per discharge. And this is pretty broadly across different cost types, though there's that notable increase in the diagnostic radiology that we get. But in any case, none of this seems to, neither of these outcomes seem to be varying across the reported injury or the severity of it, or anything that you might expect that they would follow. Next slide, please. Okay, so the things that I would like to focus on here, and of course Caitlin talked about this to a large extent, but I think it's just so important in measuring what the true costs are of this malpractice risk. It's just what exactly is behind the increase in, or the decrease in discharges. So they can, it's convincingly present that they are seeing fewer patients. But is this exactly through fewer shifts worked, or is it through fewer patients per shift? So are they moving more slowly through patients? They find that it's not a result of the physicians leaving the practice altogether. However, they are moving to hospitals more frequently after the report happens. But I think the big one, and they do some robustness checks on this, is are they sending more of their ED patients into the hospital for inpatient admissions? Thereby that discharge no longer really showing up, what you would think of as a discharge of them actually not showing up as a discharge in their data for them, and in some sense avoiding risky patients. Okay, so they find through these robustness checks that there is no change in the composition of the discharged patients. But I think that's something you could focus on a little bit more. You might think of, if you feel like you haven't done enough robustness checks, maybe thinking about who's high risk there, and who's not differently, because this is something that I would really want to rule out as a possibility of, it's just that they're admitting more patients to the hospital So we might think about some different ways to categorize the patients as well. And next slide, please. Okay, thanks. So I would focus really quite a bit more on the mechanics behind this decrease, as I said. So are they seeing fewer patients for care ever, or are they just sending them to hospital admissions? And this is going to be, I think, a really important result for measuring the true cost of malpractice risk and the true amount of defensive medicine that's happening, just because inpatient care is incredibly expensive. And so this is probably already happening to a large extent already. So even without the presence of the report, there's probably a high rate at which the ED physicians are sending people inpatient when they wouldn't otherwise if there were just no general risks of malpractice insurance. But so it's beyond a really already high baseline, but that would make it even a bigger deal if that were still occurring just due to the reporting. I know the data is really limited in this sense, as Caitlin mentioned. Is there anything that institutionally or just practically or culturally that would tell us whether after somebody gets a report, do their supervisors say, okay, you're going to take on fewer shifts here, or do they request fewer shifts? I guess I'm just wondering what's under the control of the physician. So do they have a choice in this labor supply? So typically we'd think of that as being under their control, but I don't know if most contracts would actually work that way in an ED department. And if so, is it coming from the physician, or is it encouraged by supervisors? But also, just again, anecdotally, do people tend to move through patients more slowly? It seems like they're not avoiding certain types of patients necessarily, but are they moving through patients more slowly, or sending them to inpatient care? So really, what's under their control? And I think just understanding a bit institutionally about what happens after a physician receives a report could be really important. So maybe an anecdote here would be worth 1,000 robustness checks, just understanding what the actual process is once somebody receives a report. And similarly, do any of these choices, if they are indeed choices that they're making as far as whether to see fewer patients per shift if they're moving more slowly, or taking fewer shifts, how do these affect their actual compensation? So they might be decreasing their risk of a future report, malpractice report, but do they pay for that in some way in terms of actually earning less? So how do the mechanics work for these choices, and what do they pay in a sense for avoiding these risks? And then next slide. Okay, and just finally, so while these malpractice allegations don't seem to have a direct financial impact, which is again one of these surprising things to me, not knowing about this world much. While they don't seem to have a direct financial impact through either if there's a resolution or a settlement, or even facing higher premiums in the future because premiums are community-based here, are they going to be affected in terms of their salary? Are there any measured costs that we could capture here, just to figure out what sort of costs they're facing, because right now it just seems like a lot of it might be some emotional time that's making them have fewer discharges, but maybe there's a bit more going on there. And then just other, and this is the easiest thing, much easier than a lot of things you do. I would just look at log discharges as an outcome. So I'd take a log just because the volume seems to be so important just for the instance of a report. So that might be a simple thing to do that could be interesting or not. And then finally, maybe less simple to look at, which you did mention, was thinking about what the effects are for other physicians who are within that department. Are they actually seeing more people at the same time that these people are seeing fewer? Is there any data you could get on movements to inpatient care? I know that's a big stress, but just seeing what's happening within the same hospital, because you do have that information, and that could potentially at least rule out this idea that they're sending more patients into the hospital, right, away from their care. So so that's all I have. Thanks a lot for the opportunity to read this and discuss it.
Great, thank you, Lindsay. Caitlin, do you have a big picture response before we move to the author rooms?
Yeah, I'll do a very quick response first to one of Lindsay's points and then to a couple of the comments that came up. So I think one thing you bring up, Lindsay, is, I would put it, is this a physician supply decision or a hospital demand decision? Like, do hospitals not want these physicians anymore? We spent a lot of time trying to get at that, and I think we just don't have the sample. So we're raising it as what we think is a very interesting point for future research. And then, so Amanda asked, like, what are common types of allegations against physicians? I'm not totally sure what you meant, Amanda, but like the most common clinical type is some sort of chest injury, which is sort of out of proportion with how often it happens in the ED, actually, which is sort of interesting. Abdominal injuries are very common also, but that's in proportion to their frequency as discharges. And then time costs came up a couple times. Like whether physicians are working less because they are spending all that time on the claim. The short answer to that is the magnitude of our results far exceed any documented like time costs of a malpractice claim. But we do find a lot of evidence that like psychic costs seem like they are large. And as soon as the claim is resolved, we're seeing a bit of recovery in volume. So I know we're over time, so I'll leave it at that. And I'll answer other questions in the author room if people have them.